and we are pleased to have him today with us as a moderator. My name is Dr. Talal Nizi. I'm a consultant of medical genetics and metabolic at Prince Sultan Military Medical City in Riyadh. So we're gonna open our ceremony today with a family experience and a family testimony on Gaucher disease. Patient, they have one son affected with Gaucher disease, and he will tell us about things related to the patient perspectives regarding the diagnosis, the history of the patient, the outcome, and his experience with the enzyme therapy. So the family now already. طبعا he is our patient. We diagnosed him 3 years back with Gaucher disease. He's presented to the clinic with a history of bone pain and bruises and splenomegaly and with low platelets. We diagnosed him through the enzyme assay and gene testing, and it was positive for Gaucher disease type 1. And we commenced the therapy 3 years back, and he showed very good outcome. Hopefully that the family will join us to tell about their experience with the enzyme and the disease itself.
Maybe meanwhile, as we are getting into this, thank you, Dr. Talal, for introducing me. And I would like to thank Sanofi Genzyme. I don't know if Genzyme still is used as only Sanofi. So you are completely French now. So just to thank you for putting this meeting together. And I just got to know from Zahran that October is the month of Gaucher disease and Niemann-Pick, or what is now being called acid sphingomyelinase deficiency. I've been seeing these patients for over 25 years, and this is the first time I know that October is the month. So I will need to learn more about the history of this from you guys. Maybe we should have each month a one rare disease or 2 rare disease month, I suppose. And Gaucher disease and ASMD are one of the most common lysosomal storage disorders, probably after Niemann-Pick C, or maybe equally as common as Niemann-Pick C. And we have certainly a share of these patients in Saudi Arabia. And I'm so pleased to see our younger folks, Dr. Talal, Dr. Malak, Dr. Dalal, being with us and giving us and sharing with us our experience, their experience with these disorders. So thank you for inviting me. Thank you all for being here, and would love to hear the story of your patient.
That's it. Okay. Assalamu alaikum. I'm Turkey.
هلا عليكم السلام، حياك الله.
أول شيء جدا مشكورين وممتنين على حضوركم اليوم، قبول الدعوة. معك الدكتور طلال. أنا ودي أسألك أم تركي عن تجربتكم مع حالة تركي الله يشفيه قبل التشخيص، الأعراض اللي كان يعاني منها، وكذلك تأثير هذه الأعراض عليكم كيف كانت؟
أول شيء حياكم الله جميع. طبعا تركي من ولادته ما لاحظنا عليه شيء. بدأت طبعا تقريبا رحلة علاجه من يوم عمره 2 سنين تقريبا. الصوت واضح؟
اي نعم الصوت واضح.
تقريبا من يوم عمره 2 سنين لاحظنا عليه عنده حركة لا إرادية في رأسه. كانت هذه الحركة مرة ملفتة، يعني تقريبا بين يوم وليلة كذا نمنا صحينا الحركة يعني كانت فاجعة لنا كلنا. طبعا على طول أنا راح في بالي كأم، قلت أكيد إنه طاح على رأسه، يعني قلت أكيد إنه هذا الشيء إنه طاح على رأسه. طبعا رحت المستشفيات، رحت سويت له أشعة مقطعية، قالوا كل شيء سليم، أبدا ما في ولا شيء. طبعا خلاص يعني قلت الحمد لله ما دام أموره تمام وكذا. جلسنا تقريبا، بعدها لاحظت عليه أنا عدسة العين تتحرك، يعني الرأس يتحرك في المكان اللي يبغى يطالع فيه، بس العدسة حقت العين تتأخر بثواني. طبعا أنا هنا بديت أقلق. ليش؟ لأن من أقارب زوجي كان عندهم مرض، بس هذا الكلام قديم يعني. طبعا تشخص مرضهم أن تشوه في صمامات القلب. طبعا أنا يعني يعني من ملاحظة إنه نفس الحركة اللي في نفس الأولادة. طبعا أنا آخر واحدة حضرتها يعني تقريبا كانت كبيرة، يعني يمكن تقريبا كان عمرها 19 سنة، والباقيين طبعا توفوا، يعني تقريبا كان عددهم 5. فعلى طول أنا رحت تركي، رحت راجعت فيه وكذا، وسويت له أشعة للقلب وكذا، قالوا ما في أي شيء، يعني ما في أي شيء، سليم جدا، عنده ارتجاع فقط بسيط. طبعا قلت الحمد لله يعني أمورنا تمام. رحت راجعت كذا مستشفى، طيب إيش سالفة حركة الرأس هذه؟ كمان أولادها كان عندهم نفس الحركة بس مو زي تركي كان مرة قوي، يعني ملفت للانتباه. هم لا، لما الواحد يسولف معهم كذا يعني يلاحظ بشيء بسيط. أبد والله الحمد لله يعني، من مستشفى لمستشفى، علاجات، مراجعة عيون، كل شيء سليم سليم. بعدين تقريبا يوم صار عمره 7 سنوات بدأ عنده صداع يعني بس مو مزمن زي الآن. كان تقريبا مثلا مرة بالشهر أو مرة كل شهرين، إلين صار عمره 9 سنوات. بعد 9 سنوات صار الصداع عنده يعني مزمن تقريبا شبه يومي. بس والله بدينا في العلاج. أنا طبعا كأم يعني ساءت نفسيتي. لاحظت علي واحدة من زميلاتي في العمل، فقالت لي خلاص بكلم لك دكتور عندهم بروفيسور اسمه علي بن علي ونشوف يعني. أبد والله رحت عنده أو حولني على مستشفى العسكري ب5 مشيط عند الدكتور سعيد طالع، وعلى طول يعني أخذ التحاليل منه وأرسله لألمانيا، وبعدين جت النتيجة إنه مصاب يعني الحمد لله بالداء جوشير. فهذه هي رحلة علاجنا مع تركي.
إن شاء الله أجر وعافية يا أم تركي.
يعافيك.
بعد التشخيص الوراثي يعني كيف تعايشت مع حالة تركي، وهل عانيت من صعوبات معينة متعلقة بالحالة؟
إيه. الحمد لله إنه في علاج، يعني الحمد لله إنه توفر، يعني حكومتنا الحمد لله توفر لنا العلاج والعلاج كم يعني باهظ يعني الحمد لله هذا وحده، يعني الحمد لله الواحد يستشعر النعمة. كمان الحمد لله لاحظت عليه تحسن. يعني هو كان عنده انتفاخ بسيط في البطن يعني بحكم التضخم الكبد والطحال. مع العلاج الحمد لله يعني اختفى التضخم هذا. كمان ارتفع عنده نسبة الحديد. يعني هو الصداع، هو مشكلتنا في الصداع لسه إلى الآن يعني.
طيب أثناء العلاج الإنزيمي ما هي التطورات الصحية اللي بدت على تركي، وكيف تغير من الناحية الدراسية والاجتماعية؟
والله الحمد لله يعني أموره يعني الحين تمام. يعني صار بالنسبة للدراسة يعني لاحظت أنا والله يعني، بس ما كنت أتوقع لو 1% إنه العلاج له دخل يعني. بس الحمد لله أنا لاحظت يعني هو في البداية كان عنده مرة صعوبات، بس بعدين الحين في الوقت الحالي لا، صار يتجاوب معايا، صار يعني يفهم علي. أول لا مستحيل، كان عنده صعوبات. الآن لا الحمد لله يعني إن شاء الله أن الأمور تمام، وربي يكتب الشفاء إن شاء الله.
الحمد لله، إن شاء الله أحسن إلى أحسن بإذن الله. أثناء
الله
فترة الحجر الصحي أيام كورونا، هل واجهتم أي تحديات مع انتظامكم على العلاج، حضوركم للمستشفى؟
إيه لا والله الحمد لله يعني كانت مسهلة لنا. كمان الحمد لله مواعيده كانت في وقتها، يعني ما تأخرت حتى بيوم، يعني نفسه بعد كل 14 يوم يكون علاجه، كان يعني مواعيده متواجدة. كمان يعني من ناحية الذهاب إلى المستشفى وكذا، يعني الحمد لله في تيسير وسهولة، يعني الحمد لله.
ممتاز. مشكورة على حضورك يا أم تركي، وجدا مقدرين على وقتك. إن شاء الله هذه التجربة يستفيد منها كل شخص مريض أو أسرة مريض بمرض جوشير بإذن الله.
إن شاء الله بإذن الله، إن شاء الله يا رب. اشفي كل مريض يا رب. شكرا لك.
يعطيك ألف عافية.
هلا والله، حياك الله.
Okay, thanks for Turkey, the mother of Turkey, for her telling us the experience of their experience with Gaucher disease, as they have a baby affected with the disease. So we'll move to the speaker. Dr. Main will introduce him to us.
I think is it a her or her?
To her, sorry, to her, definitely.
Okay, I would also like to welcome our virtual audience. I think it's just to say a word. Thank you for being with us, and hopefully the program will be of interest to you, and you will go back with some important messages, and to improve the diagnosis and the management of patients with rare disorders, and specifically here lysosomal storage diseases. So it is my absolute pleasure to welcome Dr. Malak Al-Ghamdi. Dr. Malak is the head of the medical genetic at King Khalid University Hospital and King Saud University. I think she's also the head of the Biobank in College of Medicine and Research Center. If you want to take an example of how our young colleagues are influencing the advancement of our cause towards the diagnosis, management of rare diseases, I think she is a prime example of how much work she has put in the university to really, with tremendous amount of challenges, to really being able to see the patients, diagnose them, manage them. So that is really a great amount of work that we all appreciate, and I'm sure she will be rewarded for it, bi'idhnillah ta'ala. So Dr. Malak is going to talk about the role of multidisciplinary teams in the treatment of Gaucher disease.
Assalamu alaikum, and thank you so much, Dr. Main Said, for your nice introduction. It's one of the best introductions I have heard in my life. Thanks for the audience, for the attendees on site and virtually, and thanks for the organizing committee for inviting me. It's really my pleasure to talk about this rare disease and give more awareness to all of the medical geneticists and other specialists regarding Gaucher disease. However, the topic was kind of broad, talking about the multidisciplinary approach in a multi-system disease. Multidisciplinary approach is the usual approach for complex diseases with multi-system involvement. For Gaucher, maybe it's difficult and more unique because of very heterogeneous disease, variable presentation, variable severity, response of the therapy, even different classification on category of the disease. So the content would be a Gaucher disease, just a quick overview, and then the impact of Gaucher disease, skeletal manifestation, hematological and visceral. Will go through them and give some risk factor, how to identify it, what is your expectation, and how to manage it. And then other non-specific pathologies as well, or infrequent pathologies, and management of Gaucher disease. So Gaucher was discovered initially by Charles Gaucher in 1882, and then the enzyme later discovered in 1966 by Brady. It caused by biallelic pathogenic variant in GBA gene, resulted in enzyme deficiency and accumulation after that of metabolites or complex lipids. It's considered rare autosomal recessive disease. However, it's one of the commonest in lysosomal storage disease category. This is just complex maybe, but really it can just showing the pathogenesis of Gaucher disease. starting from enzyme deficiency resulted in accumulation of glucocerebrosidase and glycosphingolipids and lysosomes. And I cannot see my slides here. Anyway, so the accumulation of these metabolites and lysosome resulted in cellular dysfunction. The tissues or the cells that are born are more of membrane-rich tissue, or with high turnaround membrane turnaround. Those like myelin and CNS, and also in macrophages, reticuloendothelial systems. And then we can see the pathology after that more in the cells that contain more of reticuloendothelial cells and myelin tissue. And this macrophages in the spleen can resulted in a splenomegaly, and then in the bone marrow resulted in pancytopenia or thrombocytopenia, the commonest. Kupffer cells in the liver causing hepatomegaly, and then pulmonary involvement, bone, osteoclast in bone causing bone crisis, radiological evidence of bone diseases, and neurologically, usually for type 1, is indirect effect of neurological involvement apart from some sort of Parkinson's disease, and also peripheral myelin in the peripheral nerves also affected. This is a common slide showing just the continuum of Gaucher disease, starting from asymptomatic, ending by fatal prenatal diseases with hydrops fetalis. In between, you might have skeletal, visceral, hematological, neurological, and other than maybe ocular changes, peripheral neuropathies, and skin changes. Those patients also usually need to be screened for other diseases because they are at risk of other complex cancer or Parkinson's, other diseases that are not directly related. Mechanism of skeletal changes starting from accumulation of Gaucher cell in the bone marrow cavity might be the first mechanism is just a mechanical with the pressure, local pressure causing some thrombosis and infarction, which resulted in the phenotype of bone marrow bone crisis and avascular necrosis with thinning of the cortex. Or it might change also the activated macrophage and causing local tissue damages in the bone, as well as changing the microenvironment with pro-inflammatory macrophages, and then activating all changing the immune system there with the resulted in the osteopenia and decreased bone density. Skeletal changes is the debilitating one in Gaucher patients need to be screened, and if it's there, it's really one of the manifestation, one of the features that you have to give attention. Osteopenia is very common, nearly in 65%, even with the mild disease. The highest prevalence in the adolescents, the bone that is involved usually adjacent to bone marrow sites with the infiltration. It can affect trabecular bone, and cortical bone can be localized or generalized. It's usually increasing risk of osteoporosis, pathological fracture, and joint collapse. That was common pre-enzymatic era, and after the enzyme replacement therapy, these symptoms usually improving. For bone marrow, for a bone crisis, sorry, my slide's not very clear. For bone crisis here, it's not that common. It's about 10% of the patients. However, it's really intense pain, and it's really crisis, as it's mentioned here. More frequent in children and adolescents is more, most frequently involving femoral head and shaft, but also other parts could be involved. Commonly, it's spontaneously starting in children and adolescents, but sometimes triggered by fever, triggered by anemia or other factors, usually accompanied by localized tenderness, swelling, erythema, and fever. Radiological or negative radiology or absence of radiological changes might be present. However, you might detect the ischemia with technetium scan, or also by a CT scan, you can see some edema around it. Recurrence could happen at any location or different locations. The crisis is usually characterized by deep pain, starting dull aching pain over a period of time, increasing the intensity, very difficult to control, severe pain, and then go back to the intense pain that might persist for a few weeks. The pathology behind it may be infective process that is not recognized within the bone cells here. The second one is the vertebral body. This is less common than others, and it causes some extensive collapse of vertebral bodies. Might be very occasional gibbous deformity, spinal cord or nerve collapse. Delayed collapse of the vertebra sometimes occur after trauma, or sometimes it can be also a progressive process. Vertebral involvement with collapse most common during pubertal growth spurts, and after that, slowdown of the disease progression happen after puberty. In children, they might have acute hip pain that mimic leg calf spurs disease, but rarely the presenting symptoms. In adults, they might have femoral neck fracture later in third or fourth decade or later, usually in the area with pre-existing bony lesion and accompanied by osteoporosis. If you have a Gaucher vertebra or femoral bone or other bony disease later in life, you need to rule out malignancies. Early diagnosis and early picking up these features earlier is important because to prevent irreversible bone damage. This is also a skeletal, this is the stages of skeletal changes. It starts with diffuse osteoporosis, a tubular bone with vertebrae, and then medullary expansion that cause Erlenmeyer flask deformities, then localized destruction with a small erosion, causing ground glass swelling, ischemic necrosis or sclerosis, patches of densities, and then diffuse destruction. This is stage number 5. This is just to show the Erlenmeyer flask deformities, the commonest in pediatrics, 49%, and it might be symptomatic or asymptomatic. Here is the many patients with your radiologically significant Gaucher have few or no bony region. About 100% will have radiological evidence of bony disease, and the commonest is marrow infiltrate. Radiological also changes can be seen in up to 97% of untreated patients. The commonest of them is Erlenmeyer flask deformities of the femur. Going next to the hematological changes, again, will show the pathology behind it and the risk factor to look for. Cytopenia is kind of universal in all untreated Gaucher. Cytopenia or anemia, thrombocytopenia, leukopenia might happen simultaneously or independently. Hematological abnormalities reflect the effect of infiltration by Gaucher cells and also hypersplenism. Thrombocytopenia and anemia common upon presentation, accompanied by hepatosplenomegaly, and can be variable but not linearly related to liver or spleen volume. Younger patient at higher risk of hepatosplenomegaly and thrombocytopenia. As bleeding is one of the commonest presentation, thrombocytopenia is the commonest finding or the commonest peripheral blood abnormalities, early secondary to splenic sequestration, later secondary to bone marrow infiltrate. It can cause bruises as well, not only easy bruises, overt bleeding, particularly with trauma or surgery. Also, they have other coagulopathy 9, factor 10, and Baldwin brand antigen, possibly due to the presence of higher amount of glucosylceramide in the blood. Anemia usually mild. If you have severe anemia, look for secondary reasons like vitamin B12 deficiency or iron deficiency, and if it's present, usually with severe variants. Leukopenia also mild, also very rare, and not usually requiring any intervention. And all of these changes secondary to hypersplenism or bone marrow infiltrate. The third one is the hepatosplenomegaly. Younger patient at higher risk of hepatosplenomegaly, they're at risk of splenic infarct and usually associated with pancytopenia. Due to the risk of splenic infarcts and other risk factors, splenectomy might be indicated or needed for these cases. Pulmonary involvement, uncommon, 1 to 2% in patients. However, if it's there, it's lethal and needs to be looked up and treated earlier. It might present with severe pulmonary failure or pulmonary hypertension, infiltration of lung alveolar or interstitium by Gaucher cells, in children. It might happen even without Gaucher cells in the lung. Severe pulmonary hypertension associated usually with heteroallelism for this variant in 7.3S and another variant with splenectomy and with the female gender. These are the risk factors for severe pulmonary hypertension. And then the second or the third one is the right to left intrapulmonary shunting, which is secondary to liver disease. Clotting usually in cytopenias is the, dyspnea is the features for right-left shunting. Other rare pathology we can say is neoplastic disorders, particularly in the blood-forming organs, more common in patients with Gaucher disease. Overall risk of developing cancer, especially multiple myeloma and lymphoreticular cancers, reaching 22-folds over the ethnically matched population. Lymphoproliferative cancers, including CLL, multiple myeloma, Hodgkin, and non-Hodgkin. Also, they are at risk of monoclonal and oligoclonal gammopathies, which is documented usually in higher patients and higher in patients with Gaucher and elderly, causing a risk of multiple myeloma. Bone tumor, another pathology that might be detected or found in patients with Gaucher, like osteoblastoma, malignant epithelioid, or hemangioendothelioma. Reported in a few cases only, not really. Increasing risk of Parkinson's, that's really, reading about Parkinson's and Gaucher disease is really kind of complex, no clear pathology to link, no clear mechanisms to see what is the association, or what's the cause of increasing risk of Parkinson's in patients with Gaucher disease. However, it was seen that relatives with obligate carriers of GPA mutation having higher incidence of Parkinson's disease. And also further investigation showing GPA mutations, most common susceptible factor for Parkinson's disease. Multi-center analysis reveals odd ratio of 6.4 of Parkinson's patients being heterozygous for GPA mutations. This association shown to be independent of a specific mutation or a specific ethnic group, starting early, higher male to female ratio, they are lobar responsive, and they are less cognitive achievement. Mechanism not very clear, lots of mechanistic models written, but nothing really clear about it. Neurological symptoms, most of them are indirect, caused by spinal cord compression, nerve compression, or polyneuropathy. The compression usually secondary to skeletal changes and might cause radiculopathy in many patients. Others, like thrombocytopenia, can cause increasing risk of bleeding, fat imply increasing risk of stroke, and also they are at higher risk of polyneuropathy, as we mentioned at the beginning. Gastrointestinal manifestations, again, it's indirect, nothing directly related to the disease itself. It's just due to the hepatosplenomegaly. They are at risk of having poor appetite due to early satiety, fullness feeling, resulted in failing to thrive or growth retardation. They have frequent diarrhea as well. The few cases reported with lower intestinal bleeding due to the colonic infiltrate of Gaucher cells and gastric splenosis. Protein losing enteropathy reported in one case due to the massive mesenteric lymph node infiltrate with Gaucher cells. Immunological changes, they are at risk. They are not immune compromised. However, they are fragile enough to increase the risk of infection, and they have sometimes episodes of fever that is not related to bone crisis. This could be secondary to defect, neutrophil chemotaxis, and monocyte dysfunction. Usually in pediatrics, they have polyclonal gammopathies, and in adults at risk of monoclonal gammopathies, which increase risk of multiple myeloma. Cholelithiasis also was very clear features or was linked to Gaucher disease. The prevalence is 32 or 5-fold higher in Gaucher than controls. Prevalence was higher in women, increased with age in both gender. Patients with gallstones more likely to be asplenic, higher LDL cholesterol, and more severe variants or more severe type of Gaucher disease. The bile lipid composition was abnormal and contained glucosyl ceramides, which might explain the explanation or the pathophysiology behind it might be secondary to metabolic syndrome in Gaucher patients. Infrequent manifestation like skin changes, they have diffuse brown yellowish pigmentation and easily tanning. Colloid in babies not with type 1 for acute neuropathic Gaucher resulted from abnormal glucosylceramide cleavage in the skin, which is essential for normal skin permeability and maintenance. Ocular feature, a few cases reported with brownish mass of Gaucher cells, and also corneoscleral limbus of the eye, Gaucher cells presented as well in the vitreous of the eye. Also, it was shown on the colonic polyps and maxillary sinus. Just a few case reports that they have seen Gaucher cells in the polyps, but nothing really, not a lot of the patients having this. Lymph nodes, they might have lymphadenopathies, enlarged lymph nodes. As we mentioned, massive enlargement of mesenteric lymph nodes causing diarrhea sometimes. Few cases having neutropenia, proteinuria, which is secondary to glomerular changes as well. But again, this is very infrequent and non-specific manifestation of Gaucher. One important topic of Gaucher disease, pregnancy and Gaucher disease. Gaucher disease is not a risk factor for infertility. There is no evidence of decreasing fertility in women with Gaucher. Pregnancy just might exacerbate or triggering the disease and the manifestation of disease. They are just considering the features. We can manage the pregnancy properly. They are at risk of thrombocytopenia and anemia, which might increase the risk of delivery and pregnancy. Hepatosplenomegaly might affect the fetal growth and increasing risk of bone crisis as well. They are at risk of spontaneous abortion. The skeletal manifestation as well with the breastfeeding might increase in bone crisis and the skeletal changes in those women. So management, going to the management, I'm not going to go through the exact management and the outcome and the evidence and the updated details of management of Gaucher disease, just giving an overall plan of how to treat and who should be involved in Gaucher disease treatment. So to give in your mind just general consideration for all patients with Gaucher, cover them properly, nutritional supplement, and give them a good dietary plan. They have to be seen by a neuropsychological specialist and followed by them. Just check every now and then their quality of life and see your treatment effect on the quality of life. Standard of care, first you have to quantify your phenotype and then give the proper targeted therapy, either enzyme replacement therapy or substrate reduction or both of them together. Then personalized your care. You might give an adjuvant therapy according to the signs and symptoms you have. Keeping in your mind the goal of the treatment. You need to stabilize, improve, or reverse, if possible, the clinical manifestation. This is really what we mean by multidisciplinary team approach. You need all of the team involved. They need to be expert in the disease. They need to expect the phenotype before and screen for the complication or potential complication and treat before the deterioration or prevent before. In Gaucher, we're expecting psychologist, endocrinologist, biochemist and orthopedics, hematologist, very important, radiologist and orthopedics, geneticist, metabolic specialist, general pediatrician, and home care as well. The multidisciplinary approach or team care, it's just managing the multi-system disease, which require approach that include disease-specific therapy and with supportive care. Succeed to success your multidisciplinary care, you need to have a whole team approach with clarity and the rules for each of them, and with frequent meeting to see your approach and to see your progress in the treatment. You need a regular communication, as we mentioned, and regular meetings, access to full range of therapeutic options, provision of care in line with the standard and treatment decision based on adequate information, Patients should be involved in their care and discussion and management and should receive timely and appropriate information regarding their response to the treatment, regarding your plan, and then selecting the appropriate team members. This is just a quick overview and might be longer list even to give us a general consideration. As we mentioned, they need a dietary supplements, they need a feeding gastrectomy sometimes. You need also to help knowing the pathophysiology behind the feeling to thrive. You need to give more attention to the volume of the spleen and liver to improve their appetite. Genetic counseling, keeping in your mind heterozygous pack carriers and Parkinson's disease and the family planning and reproductive options. Psychological, managing the expectation of the patients and their family is very important goal when you treat them or when you approach them psychologically. Regular and comprehensive follow-up using validated measuring tools and update your measuring tools according to the literature updates. Also keep in your mind exercise and sports, restricted some type of sports and recommended exercise for those patients. This is the goal-oriented standard of care, which is really the targeted therapy for these cases. Initially was bone marrow transplant replaced by enzyme replacement therapy, and which improve the quality of life after 1 or 2 years, and improve skeletal visceral manifestation, and might not really effective in the neurological type of Gaucher disease. And then substrate reduction therapy also demonstrates safety and efficacy. For some patients, you need to combine both, which they call it multimodal approach, to combine more than modality of treatment in one patient. This is the personalized approach to ensure the treatment goals have been achieved, regular follow-up needed. Setting up your goals and monitoring the therapy is important factor to optimize your management and providing personalized care. In some cases, you need adjuvant therapies like symptomatic treatment, splenectomy, if you have a massive splenomegaly, and thrombocytopenia. Supportive care needed in some cases, transfusion to treat anemia, or pleading, anticoagulants, sometimes in severe thrombocytopenia and coagulopathy, analgesia and hydration for bone pain, joint replacement surgery to relieve sometimes chronic pain and restoring the function of the joint. Anti-bone resorptive agents, calcium, vitamin D for osteoporosis and bone and osteopenia. This is the individualized approach or personalized approach. You need first to specify the phenotype or classify the phenotype and then quantify the phenotype, seeing the severity of the symptoms and the severity of the symptoms across different organs. Check the response of the therapy and course of the disease with life expectancy. Try to optimize your therapy according to these factors and adjust the therapy with each visit, keeping in your mind more than even these factors, but these are some examples of how to personalize your therapy. Just overall therapeutics goal to keep patients within the normal limits regarding platelets count, hemoglobin, splenomegaly should be within less than 2 times of normal size. Hepatomegaly also controlled. Skeletal pathology, giving them, as we mentioned, vitamin D supplementation, pamidronate needed sometimes. Try to normalize their growth and overall improving their quality of life. Okay, this is maybe a difficult question. How to conduct multidisciplinary approach? If it's possible, comprehensive Gaucher Center, they can do it, and all of the specialists there are experts in treating Gaucher patients. If not, build up your team, involve a different range of specialties, a practitioner, supportive care provider, explain for each of them their roles and according and expertise, select the right people, and maybe it's better to keep them fixed, not to change them within one team, to trying to build a personal expertise in each of them, defining their treatment goal, and then ensuring your treatment goals might be with good communication and regular meetings are necessary to ensure their goals. Thanks, and I'm very sorry for a long presentation, but this is really a kind of multidisciplinary approach for Gaucher.
Thank you very much, Dr. Malak, for overview of the multidisciplinary need for the care for patients with Gaucher disease. was very nicely presented, all the different organs that are involved, and therefore the requirement for a multidisciplinary care. I think the questions are at the end after we finish with all the program.
Okay,
So thank you very much for your nice presentation. Now it's again my pleasure to invite Dr. Dalal Boubshiet. Dr. Dalal is a clinical star in hiding at King Fahd University Hospital. She is an assistant professor, Imam Abdurrahman bin Faisal University, and head of the genetic unit, which I didn't know, at King Fahd University Hospital, program director of IAU Fellowship Pediatric Programs. I don't know what that means, but it must be something. If you are doing it, I'm sure it is successful. And really, it's a pleasure to see you. And by the way, apparently there are more than one Dalal who are practicing medicine. There is another Dalal in the Eastern Province who is an orthopedic surgeon, I believe. Yes. She shares the first and the last name. Mm-hmm. And I think she was involved in the case of Turkey that was presented by Dr. Talal initially, or maybe I'm mistaken. But so apparently you come from a background of family with a lot of physicians, I suppose. So we are really looking forward to hear from you on the bone manifestations in Gaucher disease. Please.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you, Dr. Mu'in, for this introduction. First, I want to thank the organizing committee and the Saudi Society of Medical Genetics, Dr. Amal and her team, for inviting me for this presentation. I'll be talking about the bone manifestation and Gaucher disease. My presentation will go, I don't know, the voice is high or it's okay?
That's fine.
Okay, so I'll go into some introduction, facts on bone manifestation in Gaucher disease, then the implication of pathophysiology to clinical practice. Simply, Gaucher disease is biallelic mutation in GBA1 gene, which will lead to, I think the pointer is not working. Okay, so it will lead to the enzymatic deficiency and glucosyl ceramide deposition, which will lead to formation of Gaucher cell, which will go into reticuloendothelial system and deposited in the spleen and the liver and the bone marrow. And this will lead to wide systemic presentation. The patient will present with anemia, thrombocytopenia, splenomegaly, anemia, and the bone manifestation plus the bleeding tendencies. So it's a wide range of manifestation and systemic manifestation. There's different phenotypes. We know that Gaucher phenotype is type 1, type 2, and type 3. The type 1 is the most common type. We see it in 94% of the cases. Type 2, which is the lethal form, and there's the neurological manifestation. And there is also talking about the spectrum between type 2 and 3 and what's known as Gaucher 2, Gaucher 3 disease. But still, it's like in a spectrum of disease. The type 2 is lethal, type 3, still they are responsive to enzyme replacement therapy. Okay, so the Gaucher earlier diagnosis consensus, this one was directed to those who are not familiar with Gaucher disease, the pediatrician, the internist, who did not see patients with Gaucher disease. So this is a very useful guideline. It's a very useful table. To me, the most important is the skeletal manifestation, but this major signs, if we see it, two of them is it will raise the suspicion of Gaucher disease, and we should put Gaucher disease in one of our differential diagnoses. So if the patient presents, for example, with bone pain and splenomegaly, the Gaucher disease should be one of the differential diagnoses. But if we see another factors such as listed, the suspicion will be higher and higher. So facts on bone manifestation in Gaucher. Bone disease affects up to 90% of Gaucher disease, mainly present in type 1 and type 3. Although the hematological and visceral organ abnormality may be severe and potentially life-threatening, but the bone manifestation is having the greatest morbidity and the long-term disability. What's happening in the bone is different than what's happening in the other organs. Sometimes patients presenting with minimal visceral involvement, but is having very severe bone or skeletal manifestation. So we know that the earlier treatment initiation decreases the skeletal complication. Bone disease may require a longer duration treatment and higher doses than is necessary for organ involvement and hematopoietic manifestation. So we know that the struggle is to diagnose patient with Gaucher disease. Maybe the patient who was presented today, she went to different hospitals, different physicians to reach a diagnosis. It was suggested that the mean age to diagnose a patient with Gaucher was reaching to seven years sometimes. So the earlier the diagnosis, the earlier the intervention, the better outcome for such cases. So the Gaucher registry, they tested around 1,698 patients with Gaucher disease, and they found about 82% of those cases having radiological findings at presentation. In Gaucher type 1, they had found that 94% of those cases, they had the radiological evidence of the disease at presentation. Here, this study was aiming to detect the carriers for Gaucher disease, and they found what's known as asymptomatic homozygotes. And when they tested those patients, they found 100% of them had the radiological evidence of the bone disease, 60% had the decreased bone mineral density, and 7% having this bone pain, but they are undiagnosed. So earlier it was thought that the bone manifestation is related only to the deposition of Gaucher cells, causing the vascular occlusion, the compression, and the increased intraosseous pressure, but it's more complicated. When the accumulation of the Gaucher cells in the bone marrow happens, there will be increase in the local pressure and the alteration in the vascularity. But in addition to this, there is a change in the inflammatory response and the cytokine expression. Not only this, the genetic background of the patient himself and the environmental factor may have a role in the severity of the skeletal manifestation. So it was divided into three changes, the primary changes, and those usually reversible with enzyme replacement therapy, such as the growth impairment, the osteopenia, the osteoporosis, the lytic bone lesions, and the cortical thinning. But sometimes this patient will not be diagnosed and it will go into further manifestation and they will have the secondary changes. The secondary changes usually acute onset of pain in the extremities or the back, which is known as acute bone crisis. And usually if it's untreated, it will go furthermore into the tertiary or what's known as the chronic bone changes. And this is the nightmare of the Gaucher disease, the osteonecrosis, and the complication of joint collapse. So the Gaucher disease pathophysiology overlap. There is the bone marrow infiltration. There is what's known as modeling and remodeling defect, and ultimately the osteonecrosis. I will start with the bone marrow infiltration. So the organ containing mononuclear phagocytes, including the bone marrow, the liver, and spleen, will be infiltrated by Gaucher cells. The Gaucher cells are described as eccentric nucleus with a crumbled silk cytoplasm. These cells are not pathognomonic for Gaucher. We can see them in other cancer patients, such as myeloma and acute leukemias. Diagnosis dependent on the enzyme deficiency itself. This enzyme will be tested in the leukocyte, cultured skin fibroblasts, or the dried blood spots. So Gaucher cells progressively displace the normal triglyceride-rich adipocyte from the adult marrow, initially in the axial skeleton and finally in the extremities. And this is opposite to what's happening physiologically, and this making the diagnosis of or the interpretation of radiological finding in patients with Gaucher disease very difficult, specifically in children. So extensive infiltration of the marrow are more likely to suffer more bone complications. And we know that the Gaucher is associated with high risk of cancer in general. Relative risk is 1.7 in relation to the general population. And the bone marrow-based hematological malignancy are higher risk, such as multiple myeloma. So how to assess the bone marrow infiltration? the bone marrow infiltration should be assessed by the MRI. The MRI is the gold standard type of imaging used for patient with Gaucher at baseline. When we diagnose patient with Gaucher, we will first do the MRI. So the MRI will be of the axial skeleton and the lower extremities. And there is a scoring system which is known as BMB, which is the bone marrow burden. This will score the severity of illness itself, and it's one of the best scoring. There is a different scoring system. This is one of the best scoring system to assess the bone marrow infiltration and severity of disease. The plain radiograph is usually focused only on the lesion or the area that is the main complaint for the patient, but and it can be adjuvant to the like DIXA scan, but it's not diagnostic for the bone marrow infiltration or the osteonecrosis. The modeling and remodeling defect. I will be going the growth retardation, the Erlenmeyer-Flask deformity, the osteopenia and osteoporosis, the focal osteolytic lesion, and the fractures. The growth retardation was found in 34 to 42% of patients. Children with severely symptomatic Gaucher disease often have retarded growth as well as delayed puberty. With enzyme replacement therapy, if it's begun before the growth plate closure, most of those children will reach the mid-parental height. The Erlenmeyer-Flask deformity is an outcome of defective also modeling. When we say modeling, remodeling, we mean that the osteoblast and osteoclast are not working effectively. So there will be increase in osteoclastic, which is the bone resorption, and decrease in osteoblastic activity with bone formation. This will lead to these manifestations. So the outcome of defective modeling based on bone marrow infiltration will lead to this, which starts at before puberty. The deformity usually asymptomatic and not been found to be associated with the fragility of the or fractures or osteonecrosis itself. So it's not related, it does not have a clinical impact, but it has a diagnostic purpose. The osteopenia and osteoporosis, an excess of osteoclastic bone resorption and osteoblastic bone formation leads to a net of bone mineral loss. So osteopenia is a reduction in bone mineral density, is frequent in Gaucher disease occurring in all ages and both genders and progress with age if the patient was not treated. So osteopenia may be diffuse or localized, affect both cortical and trabecular bones and suggested to occur close to the sites of Gaucher cell infiltration. So the reduced bone mineral can be detected as early as 5 years in Gaucher patient, although it's more pronounced during adolescence. It may progress to osteoporosis and increase the risk of pathological fracture and joint collapse. So the Gaucher registry has shown that the low bone mineral density of the lumbar spine is associated with the high risk of fracture of the spine femur in Gaucher patients. So patients who undergo splenectomy have a lower bone mineral density in comparison to those who are non-splenectomized. And they suggested, is it the severity of the disease itself, or it's because of the spleen was removed and the burden of the Gaucher cells went into the bone. So what we do for those patients, we do the DIXA scan mainly. So in adult patients, we take the lumbar spine and the both hips, DIXA, and we measure it. For patients less than 50, we use the what's known as Z-score. For the patient above 50 or postmenopausal women or those on a steroid, we use the T-scoring. For children, we cannot do DIXA until they reach 5 years. So this is the minimum age where we can do DIXA. And we do it as a total body, less head scan. It should be repeated every 1 to 2 years in cases and those above 50 years, but in those less than 50 years, it will be repeated every 2 to 4 years. This is a recent review about the minimum recommendation for assessment in children with Gaucher disease. So what's relevant to my talk today is the skeletal manifestation. So we need to do a good physical examination and assessment of the growth at presentation, then every 6 to 12 months. And when the patient is changing the medication or having significant complication, we need to assess him again. There is a biomarkers, the glycosyl sphingosine was found to be effective to test for the severity of the disease itself, one of the best markers now. The other markers is not related directly to the bone. So this is more likely to assess the severity of disease. It should be tested baseline, again, 6 to 12 after diagnosis, then at the time of changing the dose of enzyme replacement therapy or occurring of complication. We need to do also the DEXA and the MRI, as I mentioned before. Focal osteolytic lesion, this is very uncommon. You can see the greater trochanter. There is what's known as worm-eaten appearance, and this is a very high risk for fracture in such cases. There is what's known as silent fractures. It demonstrated in approximately 15% of the patient and usually is not associated with back pain. The thoracic kyphosis was associated more with Gaucher type 3. Bone crisis and infectious osteomyelitis. The osteonecrosis is often predicted by the recurrence of the bone crisis itself. So it's acute severe bone or joint pain associated with fever, edema, and local and systemic inflammatory response. When we do X-ray, we will see the preosteal elevation. The symptoms are often alleviated by immobilizing and requiring bed rest and analgesia. So bone crises are confused with infectious osteomyelitis, but in case of Gaucher disease, osteomyelitis is not that much common. The bone crisis is more common than osteomyelitis, so this should be put in mind. In case of bone crisis, there will not be no bacteremia and absence of significant shift of the white blood cell differentials. The bone crisis and infectious osteomyelitis can be tested by direct X-rays, but it will not be significant. Usually doing an MRI is the ideal for such cases and targeting the area of involvement itself. It may show bone marrow edema, infarcts, and periosteal reactions. So osteonecrosis is the most significant manifestation, and it can be after repeated attacks of bone crisis, the osteonecrosis happen. Sometimes it's very difficult to diagnose it early on of the disease. With simple X-rays, we will see only the severe forms of osteonecrosis. Milder or moderate form will not be seen by X-ray. If we did MRI and we are confused, this patient is having osteonecrosis or it's the bone crisis itself, we need a serial images to diagnose that patient to have osteonecrosis. So it's irreversible and frequently progressive, disabling the problem and need orthopedic intervention to restore function and relieve the pain. So osteonecrosis reported in up to 43% of adult Gaucher disease. New lesions can occur anytime throughout life. The osteonecrosis is multifocal and may be associated with higher risk in puberty and pregnancy. It significantly impaired the life of Gaucher disease, commonly causing the chronic pain and the disability. We know that the starting enzyme replacement therapy has a significantly lowering the risk of osteonecrosis. We recommend plain radiograph as a baseline initially, then images, MRI, and scintigraphy are valid methods for monitoring the acute crisis. And damaging remaining for several years mean that this is an osteonecrosis rather than this is an bone crisis. So in conclusion, early diagnosis and subsequent treatment of Gaucher disease with ERT is fundamental for significant improvement and bone outcome. Gaucher disease should be considered whenever we see a patient with a skeletal manifestation, bone pain, osteopenia, osteoporosis, osteolytic lesion, osteonecrosis, acute osteomyelitis, and the fracture, in addition to the classical features that we see it in Gaucher. So broader physician education regarding Gaucher disease and its bone manifestation will increase the likelihood to prompt detect the disease and improve the therapy. Thank you.
Thank you, Dr. Dalal, for again a nice overview of the bony manifestations in Gaucher disease. Definitely, this is one of the very important aspects of morbidity in Gaucher disease. And luckily, enzyme replacement therapy started early is quite effective in prevention of severe bone disease. I think we do have some time, so maybe if you allow me, if there are any questions in the audience, we have about 6-7 minutes. We will open this before the break. The questions, of course, later on, there's a full question and answer sessions. Dr. Talal will lead this, and probably we have also virtual questions. So let us open the floor for some questions, and if we have a microphone just for the speakers, if the questions goes to them, and as well for the for whoever wants to. But please, just introduce yourself so know who you are, and then we'll go ahead. There's one question here. Doctor, please.
السلام عليكم ورحمة الله وبركاته. دكتور وائل الملوك، استشاري الأورام، جرين كريسنت هوسبيتال.
فين دكتور؟
Green Crescent Hospital. Recently joined. I was working in SMC, Specialized Medical Center. This disease, what is the key of this disease? If the patient went to hematology, he will do a lot of investigation. If you went to orthopedic, he will do a lot of investigations for different for diagnosis of any other disease rather than Gaucher disease. So what is the key to highlight in your brain this is the disease I should search for? So if he came to me, for example, with bone osteolytic lesion, I will do biopsy as it is cancer. If he came with hematological problem, I will do bone marrow, and I might be lost. So the patient himself will be lost. Which department he should go, which doctor he should go. Even if we are multidisciplinary team, I mean, what is the highlight? What is the key of diagnosing this case?
This is an excellent question. Dr. يدور على الزبدة. Dr. Malak, can you please, can we have the mic, please, so you can suggest an answer?
So metabolic angiogenesis might be the specialty that look at the patient with all aspects, all of the features of the patients. Second, if you have bone changes or skeletal changes with hematological changes, if you have a constellation of signs and symptoms that are not really linked in your mind to like a cancer or a specific hematological disease, you might get an answer that might be Gaucher disease. For those patients, you can go to the literature and see many of them presented with cytopenia and the initial presentation, skeletal changes or radiological changes in the bone evident early in life. Again, if you get a bone marrow biopsy, you might get an answer looking at the Gaucher cells. If you go into the skeletal survey, you might get an answers with some radiological, not very specific, but like again, it's a constellation of signs and symptoms. That's why the multidisciplinary meeting or multidisciplinary team approach is important, and metabolic angiogenesis also should be involved early if you don't have a clear answer to a sign or a symptoms. They might be a help.
So, Dr. Fahad, maybe? Yeah.
السلام عليكم. دكتور فهد العباس consultant in dermatology مستشفى العسكري. كنت خطبت lecture حقتي. I will present actually it's after the break. So as a hematologist, so once you exclude malignancy, you have to exclude Gaucher. So the main presentation in these patients is thrombocytopenia and splenomegaly. So once you exclude, I will show it in my lecture, you have to exclude Gaucher disease. So all these scenarios, so all these presentations, if you look at the most accepted algorithm, okay, in the literature, it is the one with Cabellini to your team. So if you look at that, just splenomegaly and thrombocytopenia. Once you exclude the malignancy, you have to proceed to exclude Gaucher. Now it's easier now to do it with the DBS, just the drops of the blood, and it will open for you if you need the genetic or not. And most of these patients diagnosed by hematologists.
So
Thank
if you just allow me to add a couple of very quick points. In our society, family history is often extremely helpful. So, many of these diseases can be diagnosed by taking simple family history. And I have many examples in my practice. I have over 35, 40 patients with Gaucher disease that I've followed. And in many of these patients, if somebody took time and took a family history, you'll find that there could be somebody else in that family who's affected and who's been treated or who has died or who had complications that are related. That is not common for malignancies in general. The other point, which exactly Dr. Fahad mentioned, isolated splenomegaly with thrombocytopenia, or isolated mild hepatomegaly with massive splenomegaly and thrombocytopenia is an important. And then the point that Dr. Malak mentioned is a constellation of findings. So you have a spleen thrombocytopenia, but you have also bone involvement, which doesn't look like a tumor, doesn't look like malignancy. These are important signs. And finally, the chronicity of the disease. Usually in malignancies, you have an acute or a subacute event, whereas in Gaucher disease, you will find an event that is going on for months and years before they come to your medical attention, as the mother of Turkey was mentioning. So the length and how long the disease has been there speaks usually against a aggressive malignancy. Any other questions before we break? Anybody has a burning question? Everybody, okay. So I think we can take our break, and what time we should be back? Is it, guys? يمكن أكثر صح؟ So supposedly we should be back at 10 to 6, but let's make it maybe a little bit earlier, maybe 5:45 we should be back, okay? So you have just time for prayers and then maybe a coffee break. That's it? آمين بإذن الله ممتاز.
Okay, Assalamu alaikum again. Good evening. Shall we start our second part of the session today? Yeah. Assalamu alaikum. We are going to start our second part. The next speaker is our colleague, Dr. Fahd Al-Abbas. He's pediatric hematologist and director of the Scientific Research Center at Prince Sultan Military Medical City in Riyadh, Saudi Arabia. He's going to talk about the management of Gaucher disease, thrombocytopenia challenge.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. I would like to thank the Saudi Society for Medical Genetics for inviting me, and thank also Dr. Amal Hashim and Dr. Talal for inviting me. My topic is Gaucher disease hematological manifestations. So actually, medical genetics, it's very close to our branch, and I think we need them every day. So I guess in a few years, instead of doing a newborn screening for a panel of disorder, you may have just whole genome testing, and probably it may be cost effective. So medical genetics is very important to our branch. So Gaucher disease is the oldest known inherited lipidosis, and it's characterized by three manifestations: the progressive cytopenia, visceromegaly, and destructive bone disease. So this is my disclosure. I should put it in the first. So Gaucher disease, I observe a lot of people, they pronounce it as Gaucher disease, so it should be pronounced as Gaucher. So I think 30 minutes, I have a good time, not only for the platelet abnormalities of Gaucher disease. I can go through the hematological manifestations, and I will concentrate on the platelet. So what's the relation between Gaucher disease and a hematologist? So just a quick refresher. So lysosomes, basically they are the digestive system of the cell. And the lysosomal storage disorder are a group of inherited metabolic disorder. And the most common, you can see it on the bottom, is Gaucher disease. So this is the metabolic pathway, which is deficient in Gaucher disease, is the deficiency of the glucocerebrosidase enzyme, with subsequent accumulation of the substrate, mainly in the monocyte macrophage lineage, with the complications. So this is the list of the most common mutations in non-Ashkenazi. You see it in the middle, the non-Ashkenazi population. So you may ask me now, it's a Gaucher disease, it's a metabolic disorder, and you are a hematologist, why you are presenting this lecture? So in the coming slides, I will try to explain to you why I'm presenting the hematological manifestations of Gaucher disease. So if you have a patient with splenomegaly, actually, even my picture is, I like the outside picture better. The spleen is much better than the spleen I have. So splenomegaly, as a hematologist, you need to think about Gaucher disease or in general storage disorder. So this is the list of causes of splenomegaly. So if I have a patient, whether in the clinic or in the ER with splenomegaly, the first visit as a hematologist, I have to rule out malignancy. So if you see the hematological disorder, the malignancy can be hematological, such as the acute or chronic leukemia or myeloproliferative or lymphoma. And then you may think, because it's common in Saudi Arabia, the hemoglobinopathies, including sickle cell disease, thalassemia, and also other membranopathies. And then all the time infection, you have to think about it, the chronic viral infection or bacterial. And then, as I mentioned, the metabolic disorder, the storage disorder. And pressure on the spleen also is a cause. Usually we see it in the adult. So if you have a patient presenting with splenomegaly and or thrombocytopenia, after excluding malignancy, prompt investigation to rule out Gaucher disease. And this is based on the registry in 2008, which showed the most common manifestation of Gaucher disease is splenomegaly in more than 80% of the patient, and thrombocytopenia in more than 60% of the patient. And these two, both of them, hematological manifestations. And so this is why more than 75% of Gaucher disease are diagnosed by hematologists. Indeed, most of the articles written by hematologists, and most of the articles also written by or published in hematological journals. So we can speak now about the diagnostic delay of Gaucher disease. So although there is, the diagnosis of the journey of the diagnosis of Gaucher disease has improved recently, but still the diagnosis of Gaucher disease is often delayed for multiple reasons. Rarity of the disease, lack of the awareness among hematologists and physicians, and heterogeneity of the disease. All of them are the causes of delay in the diagnosis. So Dr. Malak showed you this picture, and it is clear there is heterogeneity in the disease. So previously, we know that the classification of Gaucher disease based on discrete phenotype. No, but now we are sure that it's encompasses a continuum of clinical finding, as you can see from the cartoon on the left, showing asymptomatic patient, maybe diagnosed later in life, to the right side with the lethal form. And the disease with multi-system involvement. On the right side, you can see the manifestation in children. And it's the universal manifestation is the splenomegaly. So we know that the disease can be delayed, and there is a list of misdiagnoses because of the overlap of the symptoms of Gaucher disease. The common misdiagnoses, as you can see in the list, the hematological disorder, as you mentioned, the malignancy, multiple myeloma, Hodgkin lymphoma, and also ITB. And the other skeletal disorder, it is included here in sickle cell disease, metabolic disorder, and rickets. Lipid accumulation like Niemann-Pick, Tay-Sachs, and Pompe disease, all of them can be misdiagnosed with Gaucher disease. And on the right side, you can see the consequences of delayed diagnosis of Gaucher disease to be associated with progressive disease, mainly in the bone, and also with organomegaly, and also increase the risk of infection. And once the disease is diagnosed, definitely there will be unnecessary treatment for the disease, and it also can cause significant impact on the quality of life. So now we can move to the pathological manifestations of Gaucher disease, the hematological manifestation with the management. So the splenomegaly in Gaucher disease is mainly secondary to the abnormal substrate storage. The spleen is almost universal in children. And in some reports, it may be seen in more than 90% of the patients. And the median splenic volume is 15 times the normal, and about 1/3 of the patient, they may have even higher than the 15 times of the normal of the splenic volume. Symptomatic splenomegaly with abdominal pain, ileal satiety, and cytopenias can be seen in these patients. And the focal splenic lesion, which is likely secondary to fibrosis, may continue even after the treatment with the enzyme replacement therapy. Rarely, splenic rupture may present with acute abdomen, or what you call surgical abdomen. So the liver involvement manifests as hepatomegaly, but rarely you may have progressive disease to liver cirrhosis or liver decompensation. The size usually of the up to 1.5% in most of the patients. If you have a patient with jaundice and Gaucher disease, you need to think about infection or chronic hepatitis rather than the disease itself. So prior to the advent of enzyme replacement therapy, therapeutic splenectomy was commonly performed in patients with severe hypersplenism and cytopenias. And now should not be undertaken lightly because it may associated with progressive disease in other organs. So the splenectomy should be avoided in patients with Gaucher disease because of the accelerated bone disease, increased risk of infection, GI bleeding, and liver decompensation, and premature mortality, and also deterioration of the neurological disease. This is in type 3 Gaucher disease. So in the majority of countries with enzyme replacement therapy, the splenectomy is only performed if you have progressive cytopenia unresponsive to enzyme replacement therapy, or you have suspicious of lymphoma. And the other indications to alleviate marked pressure which cannot be treated with the conservative treatment. And the last is because of the splenic rupture. So the cytopenias which is seen in Gaucher disease is dependent on the spleen status, anemia, thrombocytopenia, and even leukopenia. All of them can be seen simultaneously or independently. And it's, as I mentioned, dependent on the size of the spleen. And these are the lists, as you can see, of the pathophysiology of anemia associated with Gaucher disease. The hypersplenism is in the top of the list. Abnormal iron metabolism have been suggested with the dysregulation of the hepcidin by the cytokines released in Gaucher disease, and the high serum ferritin. Abnormalities in the late RBC precursor also was seen because of the GBA activity deficiency in these erythrocytes, and bone marrow infiltration with the advanced disease. The leukopenia with where you can see the lymphopenia more common than neutropenia. It is due to the bone marrow infiltration, and as it mentioned before, it's not that important and rarely and doesn't need that much of intervention. So this is the goal if you are giving the enzyme replacement therapy for the anemia. So your goal is to eliminate the blood transfusion and to reduce the fatigability and maintain the improved hemoglobin levels. So in adult and children, it may take 1 to 2 years after the conservative treatment. So these are a few words on the normal platelets. So they used to call the platelet the dust of the blood, because if you can see here, so if you can see on the picture that the platelet, it looks like a dot beside the RBC. But later they discovered that it's not actually the dust of the blood. It's one of the major cells seen in the blood films, and it's the dust that's just a broken RBC or endothelial cells. So the platelet count, the normal is 150 to 450. The thrombocytopenia is defined as mild from 100 to 50, and moderate from 50 to 20, and the severe is less than 20,000. So this is the electronic microscope of the platelets, and you can see on the right side the active form and the inactive form, and you can see the significant changes in the shape of the platelet. So thrombopoietin is the primary regulator of megakaryocyte development and platelet number. So the megakaryocyte are the late precursor in the bone marrow. And the list showing you the platelet turnover, where the half-life is ranging between 7 to 10 days, and about 35% of circulating platelets in the spleen. And this is to give you clear explanation why there is associated thrombocytopenia with the hypersplenism. And about 25% of the platelet in the body to maintain the endothelial integrity. So the thrombocytopenia in patients with Gaucher disease may present with a bleeding, a diathesis, or incidental thrombocytopenia. The thrombocytopenia most mild in 15% to moderate in 50 to 70%. In the non-splenectomized patients, the median count is 85,000, and 25%, about 25%, they are less than 60,000. In the splenectomized, most of these patients, they have normal platelet count, only about 15% with thrombocytopenia. And this is also just to remind that the presence of the splenomegaly with a patient with query ITB should be indication for prompt investigation to rule out Gaucher disease. And it's well known that thrombocytopenia is one of the markers for the severity of the disease and one of the markers for the response of treatment. And this is on the list. You can see the pathophysiology of thrombocytopenia, the sequestration, as we mentioned, bone marrow infiltration. And there is also some studies showing that the intrinsic hematopoietic stem cells defect associated with Gaucher disease, where the Gaucher disease mesenchymal stem cell itself, there is impairment, and the GBA deficient hematopoietic stem cell inhibiting طيب طيب هذا اللي هو ما يرمج. شكرا. لا خلاص. هنا تفضل ارتاح شوي. لا خلاص ما ممكن أبدأ. شكرا لك. سوري. فنقول hematological manifestation of Gaucher disease type 1, the bleeding diathesis, mucocutaneous epistaxis, neuralgia, thrombocytopenia is the main cause. Abnormalities in platelets can be in the function of the platelet, coagulation protein, and fibrolysis. Abnormal platelet aggregation reported in 20% of Gaucher disease patient. Normalization of platelet aggregation after enzyme replacement therapy, and pseudo-Bernard Soler type platelet defect in splenectomized patients. So the response with the enzyme replacement therapy with thrombocytopenia, the treatment goal all patients sufficient platelet to reduce bleeding and normalization of platelet count. For a patient with moderate thrombocytopenia, you may wait for 12 years. For patients with severe thrombocytopenia, less than 60,000, you continue to increase. You continue to increase with 1.5 increase in the first 1 to 2 year. For patient with refractory symptomatic thrombocytopenia, the severe thrombocytopenia where you have unresponsive to conservative treatment, or needs prompt evaluation for an intercurrent disease process, including malignancy, platelet function disorder, coagulation abnormalities, concomitant immunothrombocytopenia, purpura, YTP. And the evaluation of refractory thrombocytopenia in patient with Gaucher disease, the bone marrow study, platelet function studies as aggregation and coagulation factors. Trial of IVIG plus minus steroid can be used. Use of TPO agonist such as Thrombobag or Romiplastim, and it was seen effective in some of the reported cases, and it's good in that to improve the count of platelets and alleviate the bleeding symptoms.
If you feel tired or you need to rest, you may conclude your lecture and we move to the other lecture.
I think okay.
It's fine with
Yes,
you?
yeah.
Okay.
So in case of failure of the above intervention, individuals evaluation through multidisciplinary team if the patient is a candidate of bone marrow transplant, if there is any failure about the treatment of the disease. And then the last is the awareness among physicians. So this is a study that looked at the awareness among the hematologists, and what they found that it's only 20% of patients with hematologists, they are aware of Gaucher disease. And the study conducted, and it was well designed, over 400 hematologists and hemato-oncologists, and it was viewed through the computer, and they gave them a history of a patient with 42-year-old with the most common presentation of Gaucher disease, the anemia, thrombocytopenia, and hepatomegaly, splenomegaly, acute and chronic bone pain. And unfortunately, only 20% they reported as one of the differential diagnoses Gaucher disease, and this has showed the poor awareness of Gaucher disease among hematologists. And on the 2000 شكرا لك. So this algorithm, which was by the Capellini team on the 2001 after consensus meeting, and the algorithm, it was mainly, if you look at the two, as I mentioned, the splenomegaly and thrombocytopenia. So the first step to rule out malignancy, and even you don't need the ruling out malignancy, you may need bone marrow. However, to rule out Gaucher disease, you do need to have the bone marrow. The DBS can be the dry blood spots and genetic testing. And on the right side, you can see also the other, which may help in the suspicion of Gaucher disease. So this is just two cases from our center to show you the need for the awareness among hematologists and physicians. So this is a 12 years old boy presented with a mild recurrent abdominal pain for 4 years at the pediatric department. He had complained of chest pain more severe than the abdominal pain. He was referred to cardiology, and they did for him a Holter and the cardiac evaluation. And the physical exam at that time showed splenomegaly 4 centimeters below the costal margin and tender mass few centimeters at the upper sternal border. So he remained, the cardiac evaluation was okay. He remained a few years with the pediatric follow-up. He was referred also to gastroenterology. The abnormalities, which is more highlighted here. You can see the CBC is normal, and the abdominal pain was there, chest pain, and the splenomegaly. And he was referred to hematology because of the increased in the splenomegaly. So on the evaluation at the hematology clinic, the pain, it was pain at the chest with a mass and recurrent abdominal pain with splenomegaly. So these are the laboratory investigation. You can see the CBC was normal. However, the platelet was 161, and probably with the where the hematologist, we think it's in the low side. Yes, it's normal. It's in the low side. The coagulation screen was normal. Blood film was normal. Didn't see any abnormal or malignant cells. The inflammatory markers as liver function and renal profile all were normal. The radiologic exam showed his chest X-ray showed osteopenia, and the abdominal ultrasound confirmed the presence of splenomegaly. So in summary, this is a 12 years boy undiagnosed for a few years with splenomegaly, bone pain, and low normal platelet count, the 161. So from the first visit in the hematology clinic, we sent the patient for the enzyme measurement through the DBS and showed the low glucose repeatase, and then it was sent and confirmed the mutation, the homozygous GBA1 gene mutation. And they were also investigated for the MRI of the brain and echocardiogram. And now he's under treatment with enzyme replacement therapy. So the second case, this is a 9-year-old girl. She was referred from the primary care with poor weight gain and splenomegaly, in addition to history of epistaxis. The family was negative for any blood disorder. The physical exam showed clear failure to thrive with spleen 3 centimeters below the costal margin. And the CBC showed mild thrombocytopenia with a platelet 143. So the initial, they thought that probably a presence of portal vein thrombosis or hemolytic anemia. However, the laboratory finding ruled out the presence of hemolysis, and the ultrasound also ruled out any thrombosis in the portal vein. The clinical course, she remained for 2 years, then referred to hematology clinic. And she was for a few months, and then we thought about the storage disease or Gaucher disease because of the presence of epistaxis, splenomegaly, and thrombocytopenia. And the storage was suggested and turned to be with a dry blood spot that the patient is having an hemophilia type B. So with these cases of the delay in the diagnosis, we started the Gaucher disease awareness campaign. We started from the Prince Sultan Medical Military City. We have covered till now 4 cities in Saudi Arabia. It is about half workshop, and Riyadh, Qasim, Kharj, Wadi Dawasir, and Hail, all of them included. And after that, we were successful in the diagnosis of 2 Gaucher disease patients. And these are pictures of the activities. Okay, a few months later, after the start of the campaign, we published a review article on the overview of Gaucher disease in Saudi Arabia, and this was after the consensus meeting of 11 hematologists among Saudi Arabia. And the expert opinion actually showed that they agreed that the data on Gaucher disease in Saudi Arabia are lacking, and you need a registry for the disease to be was highly recommended by the hematologist. And also we agreed to expand the awareness, and this is this evening, this is a good example of to improve the awareness among physicians, not only the hematologists, but all the physicians. And we think that because of the poor referral system, probably it's all the physicians, they need to be aware about Gaucher disease. Later, after that, we started the project of looking at the prevalence of Gaucher disease in patients of unknown cause of splenomegaly and or thrombocytopenia in Saudi Arabia, and it was published initially in the Blood, which is under the American Society of Hematology. A few months ago, we finished from the project, and this is showing you the screening was with the dry blood spot, and the study was a multi-center, mainly cross-sectional study. It included 13 sites with tertiary hematological centers, and we enrolled 390 adults and children. And the main criteria was presence of thrombocytopenia and or splenomegaly, and to be undiagnosed for at least 12 months. So what the result showed that 86 of eligible patients with thrombocytopenia and 67% with splenomegaly. And however, out of the 390, we have 157 with sickle cell disease. So the prevalence tend to be almost 0.5% out of 233 patients without the sickle cell disease. And there was, out of the 233, there was one patient diagnosed with Gaucher disease based on the the dry blood spots, and then compared by the genetic study. And the prevalence was 0.5. If you take the whole 390, it will be less 0.2, the prevalence. Okay, so the hematologists play a pivotal role in the diagnosis of Gaucher disease, and this is the list, the one who should be tested for Gaucher disease. Patient with splenomegaly and or thrombocytopenia when the following conditions have been ruled out: hematological malignancy, hemolytic anemia, thalassemia, immunothrombocyte or ITP, splenomegaly due to portal hypertension. And on the right side, a patient with splenomegaly and or thrombocytopenia when they have been diagnosed with any of the following conditions: idiopathic splenomegaly with unknown cause, idiopathic thrombocytopenia with no known cause, atypical or unresponsive idiopathic thrombocytopenia, unexplained bleeding or bruising, and unexplained elevated serum ferritin. So in summary, the disease is rare, progressive, multi-systemic, and debilitating inherited disorder. The Gaucher type 1 is a treatable condition, and you should suspect the disease once you have splenomegaly, thrombocytopenia, anemia, and hepatomegaly with bone manifestation. Early diagnosis and initiation early diagnosis and initiation of treatment offer significant clinical benefit for the disease. Thank you.
Okay, thank you, Dr. Fahad, for this informative and well-illustrated lecture on hematological aspect of Gaucher disease. It was really conducted very effectively. Thanks for your effort.
Thank you.
I hope that you feel fine right now, inshallah. So we'll move to the next speaker, Dr. Nadia Al-Hashimi. So Dr. Nadia Al-Hashimi, she's a senior consultant, head of metabolic and clinical genetic at National Genetic Center, Child Health Department at Royal Hospital, student coordinator at Pediatric Department at Royal Hospital, trainer at Oman Specialty Board. So she's going to talk about the topic of ASMD versus Gaucher disease, differentiating manifestations. Dr. Nadia, here you are.
السلام عليكم.
Hi, Dr. حياك الله. أهلا فيك. Welcome.
أهلا وسهلا. Thank you very much for the introduction. It's really a great pleasure. First of all, before I'm starting, I would like to thank the organizer for this event, the awareness event, Saudi Society of Medical Genetics, selectively my colleague Dr. Amal Al-Hashim for her invitations. At the same time, I would like to thank the organizing company, Sanofi Genzyme, for their continuous effort in supporting like this event and in helping to increase awareness of rare disease. So I'm going to start with you a little bit different. I think you had enough information today regarding this kind of rare disease. And I will stress on what Dr. Fahad ended, splenomegaly. And even I select that title in my talk. I said splenomegaly, what else should we think of? And for this, I will take you through 2 cases. And with me, you will see the struggle, how usually this patient might present and how difficult to diagnose them. So in general, splenomegaly, I think hematology has done a lot in this field. And even we as a student, we learned a lot of long list of the differential diagnosis. And on clinical skills, I think we became an expert even as a student later on as practitioners, selectively pediatricians, to identify the spleen. And we learned that spleen might be a bulbable and the size might increase to be midclavicle line and it might be huge, extending the umbilical area. And when you look at the differential diagnosis of splenomegaly, people try to make life always easy by putting a simple word in together to get a rich, long differential diagnosis. So by this statement, his big splenic mass, you can list almost differential diagnosis of splenomegaly. And definitely when you have a huge splenomegaly, you will be more worried about the major issues like severe vein thrombosis or an infections. We are lucky enough that our differential diagnosis being among this as infiltrative disease. So people in hematologists always, they are thinking of this differential diagnosis, but most of the time their mind will be busy and occupied by an emergency situation. Moving from there to our patient, let me share with you the story of this child. So this child was seen first time at Royal Hospital 2016. And first time he presented to our colleague in the gastro, he was almost 1 year and 3 months old. And that time he had an abdominal distension. This abdominal distension was noted by the family since he was maybe couples of months. And they said he was fine, doing fine. He is a usual normal born child. Parents were consanguineous. And they mentioned immediately they had a history of liver disease in one of his maternal brother. And they said there is no transplant, although that history wasn't clear because we could not find any local documentation of that. And then the parents, they said, because he had that abdominal distension, we went to multiple centers and we being reassured. But we felt this is unusual, so we approached their local hospital. They approached their local hospital, and from there, they've been referred to the gastro clinic. But what reassured that family, he had normal developmental, normal growth, he was healthy, looking well. And the only issue that his abdominal distension is increasing with time, and no other abnormality. no other symptoms. So when he was seen in gastro clinic, definitely been in the Middle East area, selectively in Gulf countries with high incidence of consanguinity and high incidence of hemoglobinopathy, definitely you will think to rule out hemoglobinopathy. So the test ordered immediately, and it was normal. His CBC being done more than one time to reassure what's going on. They checked any inflammatory process, it was normal. So they ended by checking other organ functions, liver, and they tested the other possibility this might be something unusual. So they test his lipid, they double check that his kidney is working well, and they have checked their risk of malignancy. His alpha-fetoprotein was within normal, and he had normal coagulation. His uric acid was fine, his serum glucose was okay, his CK was normal, and his lactate within normal. And they ordered the ultrasound more than once, and even they ordered it immediately at the time when he came, and ultrasound reassured that he had huge hepatosplenomegaly, and there is no abnormal focal lesion. That reassured the team for some times, but at the end they need an answer. So after extensive workup, they decide to refer the patient to our side. Definitely they involved hematologists indirectly, but with that kind of investigation, they've been reassured, so they referred to us before the hematologist. So when I saw the child, he was 2 years old, and he was asymptomatic apart from progressive hepatosplenomegaly. He had normal growth, normal developmental, and positive consanguinity. Being a biochemical genetist, definitely I will think of storic disease. But what kind of storic disease? So this is the picture of the child. This is not the same child, this mimicking. This is one of our patients also. So you can see how huge is spleen, and also he had hepatomegaly. So lysosomal storic disease is one of the differential diagnosis, lacking other extra phenotypical manifestation. Definitely we thought of lipid-storic disease. Why selectively lipid-storic disease? Because we used to see extra manifestation in other forms of the storic disease. One of the differential diagnoses when this patient came to us also from gastro clinic was glycogen storic disease. But usually in glycogen storic disease, hardly you will have that extensive splenomegaly without a huge hepatomegaly. Usually in glycogen storic disease, you will see the opposite. The liver will be quite huge. It might reach the right iliac area, while the spleen, there will be sometimes splenomegaly definitely, but not to that extent. In addition, hardly to see a patient with that huge hepatomegaly without biochemical manifestation in terms either abnormal CK, abnormal liver function test, or hypoglycemia, either silent or symptomatic hypoglycemia. Definitely, sometimes they might have a cardiac manifestation, depending on the types of the storic disease, glycogen storic disease. So I thought this is most likely a lipid storic disease, and I was in a hurry to confirm the diagnosis. So ideally, we start to double check his echo, if it's normal or not, and definitely I requested skeletal survey and enzyme study. And the top differential diagnosis in this kind of patient is Gaucher disease, because this is a treatable condition. We do have enzyme replacement therapy. So I was in a hurry to confirm that this patient is having Gaucher disease. And I was lucky that his enzyme study showed his glucocerebrosidase activity was abnormal. His keto was reconfirmed also. It was abnormal, it was high. So they said in this report, strongly highly suggestive of Gaucher disease, and the case being solved. Do you agree? It's very difficult to communicate, but all of you agree this might be a Gaucher disease? Anything unusual? So I wasn't comfortable to just finalize the scenario, because I used to see patients with the Gaucher disease, and this is not the classical presentation of patient of Gaucher disease, although it might be, but usually an infant who started to have the disease from early infancy when he was 5 months, and now almost couples of years, hardly to see an isolated splenomegaly without CBC line defect. So I wasn't comfortable to just moved on with the diagnosis. So what I did, I said, okay, let me repeat this in different lab. So it's going on, yeah, I agree. We have low activity And at the same time, in that test itself, they tested more than one enzyme. They tested also sphingomyelinase activity, and it was normal. And they showed me his Keto was also high. And we know that most likely with this biochemical profile, this might meet Gaucher disease. But as I mentioned to you, we used to see an early manifestation of Gaucher disease in infancy, although this might be one of the manifestations, but hardly to be an isolated. And you have learned from the previous lectures, most of Gaucher disease, they will be seen by the hematologist. And hardly hematologists, they will see an isolated splenomegaly alone. Most of the time, this patient, they will have one of CBC line defect. So that was the reason I wasn't comfortable with the diagnosis. So I moved to, and I requested the enzyme activity in different lab, and the enzyme activity for Gaucher disease was normal. So just to cut it short, what I did, I requested whole exome because clinically I was comfortable. This most likely a lipid historic disease, patient being investigated more than one times, his CBC profile is normal. So I'm dealing with something else except Gaucher, and he been investigated from point of the hematology differential diagnosis, the serious condition being excluded. So I moved to whole exome. And whole exome showed this patient is having pictures of Niemann-Pick. So we have abnormal homozygous pathogenic mutation in SMBD1 gene. So this is very classical presentation of SMBD diagnosis. So if you look at the CBC parameters of this patient, you can see that this patient is having normal hemoglobin till now from the start since 2016, and now we are 2022. And he also has normal from the beginning, has normal platelet count and continue to be, and he has normal count. And this is the classical presentation of Niemann-Pick type B or SMBD. And usually they will maintain to have normal CBC profile till the second decay most of the time, and they will have the later manifestations. So currently, patient is almost 8 years, and he's having normal CBC, normal growth, good school performance, normal lipid profile. He's still having significant splenomegaly, and he's waiting for the hope. We'll move to the second case. This is another patient who was referred to us recently from one of the local hospitals. She was 4 years old, referred with a huge splenomegaly. And you might be surprised why this patient referred to us directly instead of referring this patient to the hematologist. The usual scenario in this kind of patient, before, maybe I can say before 5 years, hardly they will reach us immediately. They most of the time will be referred directly to the hematologist. But nowadays we are quite lucky because we have a trained resident who graduated from OMSB, and one of the mandatory rotation is biochemical genetist. So they have seen these cases, and it's always among the differential diagnosis. So nowadays, most of this patient will be referred to multiple services at the same times. And as not sure about the referral system at Saudi Arabia, but here in Oman, most of this patient will be seen in the secondary hospital, and they will be referred to the multiple service. Ideally, you should refer to the proper service, but because of the delay of the appointment, so from there, they will refer to the multiple. So they will refer to the gastro, they will refer to the hematology, and they will refer to the biochemical genetist. So I saw the referral, and I was worried about this patient, so immediately I called her. So we were the first one who saw this patient. When I saw her, she had huge splenomegaly, failure to thrive. She was born as BD. Her weight was 2.1. She had an IUGR at that time. And the mother reported history of recurrent infection. She'd been seen at the local hospital multiple times. She had also poor vision, and they said she had high myopia. She had some element of developmental delay. Although she was gaining milestone, but she was slow comparing to the usual peers in her age. She was investigated extensively at that secondary hospital, and this is the usual scenario. Most of the time, this patient hardly will be referred immediately. They will take their times to finalize and to frame what's going on with the patient, and then they will refer the patient. So after extensive investigation, based on local facilities, what they have, they said they could not reach any diagnosis, and they would like to get another opinion to rule out any serious conditions. And what made them worried, honestly speaking, they said the family, they came and they gave a history of a hugely distended abdomen of sudden, although this is very difficult to be accepted, but they said that what the father mentioned. So definitely what they did, they ruled out hemoglobinopathy. As I mentioned, this is one of the basic things. You have to rule it in any patient in Gulf countries who's coming with the hepatosplenomegaly, definitely in those who are lacking premarital screening. And we are one of the country where we don't have obligatory premarital screening. So CBC was abnormal. Her liver function test was questionable. Her urine electrolyte was normal. She had a head CT. The reason was not clear for me, but they said they did a head CT. Why? Not sure. And they said also they did an abdominal ultrasound. Her abdominal ultrasound showed huge splenomegaly. So moving from there, looking at her clinical manifestations, when she presented to the clinic, child was sick looking. She was pale. She looks small for her age. She was febrile. She was wearing glasses. Her abdomen is hugely distended. She looks thin. Her growth parameter all below the 3rd centile. I could not see at that time any skin lesions. She had no dysmorphic features. So I was worried, and immediately I decided to send her to the emergency department. She had documented fever for more than 39. And I said, no, we have to act immediately. So please go to the emergency. We need to rule out serious differential diagnosis. And definitely I called my colleague from the hematologist. I informed him about the case, but I told him I will admit the patient under my care. I'm strongly suspected some diagnosis, but I need your help to go further with the case. And you can list your differential when you see this kind of patient who are sick, who are irritable, and you are worried about the patient. Don't forget the serious differential diagnosis. Although you have very basic knowledge about the disease, but still you have to rule out serious conditions like, you can see from here what we order. We order ergan CBC, and we order ergan blood film, electrolyte, liver function test, and also we order immunoglobulin. And that based on the history, because we've been informed this patient, most of the time she's at hospital. So combined multiple factors and also a constellation of her clinical and biochemical finding, we thought maybe also immune deficiency need to be ruled out in this patient. And with that presentation of a huge splenomegaly of sudden, CMV was one of the differential diagnosis. We were quite worried about the HLH, secondary HLH or primary, less likely to be primary HLH, definitely. We used to see HLH and usually primary HLH, they presented earlier, although they might mimic this differential diagnosis. And if you looked at the hematologist to the parameter, what she had at the time of presentation, most of you will say this is HLH till proving otherwise. Because she, at that time, she met more than 5. So, but her fibrinogen was reassuring, although this is not a must. And she had normal thyroid function test. So ultrasound was done, also echo, chest X-ray. We ordered skeletal survey, and I ordered immediately LSD screening. But because the patient was sick and mother gave that history, and ultrasound showed huge splenomegaly, but in addition to that, they showed there is a multiple lymph node. I wasn't comfortable to leave this patient like this, waiting for the enzyme study. And our colleague from the hematologist, they said they are not comfortable also. Then we said, okay, we'll go ahead with the bone marrow, because now we have 2 differential diagnoses with presence of the lymph node. And also we are worried about the HLH. And even if it is lysosomal storage disease, bone marrow might help. And definitely it helped a lot, because bone marrow showed us a normal functions marrow and huge presentations of Gaucher cell. That being confirmed later by the enzyme study, which showed the pictures of low enzyme activity confirmed by the molecular finding, and patient started within short time on enzyme replacement therapy. She has only one younger brother who was at that time 6 months. I examined him clinically. Examination was reassured, but that is not enough. Always you have to be very careful whenever you examine clinically a young child. Don't depend on the clinical examination, don't depend on the CBC, selectively in family screening. You have to go ahead and do the test. You have to send the enzyme, and the enzyme will help you. So we send the enzyme of that child, and unfortunately he turned out to be affected. So if you look at this patient CBC right now, you can see here, when she presented to us in January 2022, her hemoglobin was 7.2. And you can see within short time, after starting the enzyme replacement therapy, we have correct her anemia, her hemoglobin almost 11.9. And you can see fluctuation in thrombocytopenia, which is not unusual in patients with the Gaucher disease. You heard from Dr. Fahad, usually this need longer time, and some of the patients, they will have persisting thrombocytopenia. It needs years to be corrected, but she maintained normal CBC. The good things, the dramatic response on the clinical basis, because her weight improved. She presented with the weight of 11, and within short time, she gained 2 kg, which is something good. Her height also increased by 4 centimeters. Her spleen size reduced, or hardly you will feel any spleen right now, and her liver size also reduced. And you can see the difference in this kind of patient when they presented and after you start the enzyme replacement therapy. Enzyme replacement therapy for this kind of patient is a new life, and you can see the changes immediately in short. Within 1 year, the patient will be totally different child. So moving from there to the lipid, and the main aim of this talk is to differentiate between Gaucher disease and acid sphingomyelinase deficiency. And from the previous 2 cases, I wish that you had seen that the difference in the clinical presentation. So patient with Niemann-Pick, usually they will have most of the time asymptomatic splenomegaly. Hardly they will have any CBC abnormality, although this is not a rule. And most of the time, Gaucher patient, they will have a significant splenomegaly and plus minus CBC manifestation and other, in addition to the other differential and biochemical changes. Most of the time, this patient might overlap in their presentation. Very difficult to decide on clinical basis to differentiate between these 2 diseases, because sometimes they might be missed if you didn't screen them by the enzyme study. So we have to be very careful. Some touch on the Gaucher disease. You heard a lot from the previous 2 presentations about the Gaucher disease, and most of you now aware this is one of the lysosomal lipid storage disease. You will have a deficiency in acid beta glucosidase, and definitely you will have a complex molecule accumulations in the multiple organ. With the time, this will damage multiple organ. It's a multisystemic manifestation, and the patient will end it by the progressive organ damage. And the main 3 types of the Gaucher disease, which we have seen, is type 1 and type 3. Type 2, I can reassure you, most of you haven't seen type 2 because this patient hardly will present to you. Most of them, they will present it in the early neonatal period, and most of them, they might present with an non-immune hydros fetalis. You might be a lucky neonatologist to diagnose this patient, but hardly this patient will stay till a time you will have a chance to see them. They will have a progressive course of disease, rapid with a meager cardiorespiratory manifestation, they will pass away. They have a major CNS manifestation in type 2. Type 1 and type 3, you have to be very careful. They mimic each other. They will have mild, and type 1 definitely no neurological manifestation. And type 3, most of them, they will have neurological manifestation, but you have to be very careful about the time of the manifestation. So this patient might mislead you till they are almost more than 10 years. Their CNS manifestation might appear later by the second decade. And although we have some element of genotype-phenotype correlation, but you don't be that much trust on this because still there is an overlapping, so you cannot guarantee. Whenever you counsel this kind of patient, you have to be careful, and you said you will, unless it's well known that genotype is associated with either type 1 or type 3. Otherwise, you have to be very careful. We had a bad experience with this kind of patient. We labeled them at type 1 and they tend to have type 3. So one of the difficulty for most of the hematologists and even sometimes pediatricians is to differentiate between Gaucher disease and other form of the hematological conditions. And because this is quite serious, there will be no time to let the patient go through the routine screening. They will be in hurry to exclude malignancy. One maybe of the good clinical finding in this kind of patient, you know, most of the hematology condition, the patient will be a normal child. Hardly he will have any chronicity except sickle cell and thalassemia. But the rest of the series, this kind of patient, they will be a healthy patient. So most of the time, hardly they will have a major failure to thrive. But in Gaucher disease, I'm mentioning this only for pediatric presentations. Most of the time, they will have failure of thrive. So you might just assess their growth parameters. This might guide you. So this patient, they will have a significant failure to thrive, and this might help in the differential diagnosis. They will have a major overlap with long list of your differential diagnosis, but this might be your entry. And always no rules. There's no clear rules in this kind of patient. And now with the availability of screening, there will be no harm whenever you collect the blood in this kind of patient to collect a simple DBS, dried blood spot, parallel to your rest of the investigation till the case be finalized. And from our experience, we have seen that we collect the DBS, people on the other side, they prepare the patient, they took serious actions, and by that time the DBS being released, not yet bone marrow being done, and that saved a lot, saved invasive procedure, sometimes anesthesia, family anxiety, because most of the time you will get the result within 10 days. So moving now from the Gaucher to Niemann-Pick. For maybe till now we are still using Niemann-Pick, although the name been changed recently to the acid sphingomyelinase deficiency. Niemann-Pick AB or B is an old name for acid sphingomyelinase deficiency. It's one of the lipid lysosomal storage disease, as also already we have seen in Gaucher, there will be an accumulation of the sphingomyelin, and this accumulation definitely with the time will lead to the major damage in the very significant and important organ in our body, like spleen, liver, lung, and our bone marrow, and definitely nervous system. And definitely there is a major similarity between Gaucher and Niemann-Pick, but always I'm afraid from Niemann-Pick. It's very silent, it sound at the beginning, but it's a big hitter to the lung and liver. So this kind of patient, they will develop early lung manifestation and early liver failure. And maybe in the literature, there is a reported cases of liver transplant in this kind of patient where the patient was not diagnosed, and that was a very serious. So as we mentioned that we have 3 forms of Gaucher disease, although an acid sphingomyelinase deficiency, we have a 3 forms. We have type A, type AB, and type B. And also type A, most of the time, this kind of patient, they presented very early in life with a major CNS manifestations, and they might presented with the huge CNS and even sometimes with very progressive, and they will pass early in life with a multi-organ failure below 2 years. Type AB, it's most of the time they will have variable between childhood and early childhood. They will have a major respiratory and liver manifestations. And type B, they will have most of the time better presentations. They will have a chronic manifestation, but most of the time there is no neurological manifestation at all. They will presented with a progressive respiratory and liver disease. Very difficult sometimes, honestly speaking, very difficult to differentiate between type AB and type B. So most of the time we face an overlapping between these types. But let us look at the other types of the lipidostoric disease. In addition to the Gaucher disease, we have acid lipase deficiency and we have Niemann-Pick C. So to differentiate between acid lipase deficiency, Niemann-Pick C, and acid sphingomyelinase deficiency, acid lipase deficiency is very serious lipidostoric disease. Although we have two phenotypes, the infancy one, hardly they will have a isolated splenomegaly. This patient will come to you very seriously, very sick. They might end it in ICU. Most of the time they develop HLH-like pictures, which is well-known, documented as one of their major manifestations. They will be sicker. Most of the time they will be admitted. Hardly they will be unstable outpatients. But Niemann-Pick disease or acid sphingomyelinase deficiency, they are quite stable patient comparing to them. And usually they will develop, and one of the also good clue in acid lipase deficiency comparing to the Niemann-Pick or acid sphingomyelinase deficiency is hyperlipidemia. It presents in both, but usually in acid lipase deficiency, it's quite huge to extent the patient might have lipidemic CBC-like pictures. They will say when you send their CBC or you send any kind of test or urine electrolyte, you receive the call from the lab. This is usually abnormal. To that extent, it's quite huge, it's quite significant comparing to the acid sphingomyelinase deficiency. And other differential diagnosis, Niemann-Pick C, also they might present with some mild phenotype, but usually Niemann-Pick C patient, most of the time they will have a CNS manifestation. Either mild one you might miss, but maybe simple eye manifestations, or a major CNS manifestation like an ataxia. So going back to Gaucher disease and Niemann-Pick, as you have seen that it's most of the time both disease, they involve multi-organ, they involve spleen, they involve liver and chest, and most of the time they might end it with a major CBC manifestations, and both they might affect. But what we have seen that the skeletal manifestation is more serious and huge in Gaucher disease comparing to Niemann-Pick. And Niemann-Pick, they will have more of the lung manifestations. But whenever you suspect lipidostoric disease, and with the availability of the enzyme study on DBS, always you select both. Maybe in the past, we used to select Gaucher disease more frequently based that we are aware there's an enzyme replacement therapy, but to save time and also to have a cost effectiveness, maybe selecting both at the same times will be better in the finalizing the patient diagnosis. Although worldwide, we are aware that the incidence of Gaucher disease is far more than Niemann-Pick. And one of the major differential clinical manifestations between Niemann-Pick and Gaucher disease is the liver manifestations and lung manifestation and hyperlipidemia. So most of the patients with the Niemann-Pick disease or acid sphingomyelinase deficiency, they will have hyperlipidemia. And then by the end of this first decade, they will have abnormal lipid profile. While Gaucher disease, most of the time they might not have this and immediately. Also, the presence of the liver disease is quite early and more frequent in patients with acid sphingomyelinase deficiency compared to the Gaucher disease. And one of the serious, since we have now hyperlipidemia, so our patient with the acid sphingomyelinase deficiency, with this present of the significant hyperlipidemia, they will be more prone to the cardiac manifestations, selectively coronary artery disease. So you have to be very careful, you have to keep it in mind. So this is a usual scenario in rare disease. Most of these patients, they will take long time to be diagnosed, which is well known. So this is, you have to follow this patient for a long time, and also you need to concentrate if they are infancy on their growth measurement, liver function test, and ophthalmology manifestations. Okay. And for adults, you have to be very careful also, where you have to list it for them an annual evaluations, and you have to concentrate on their manifestations, selective the liver, and also coronary artery disease by requesting coronary catheterizations. So since we don't have till now an enzyme replacement therapy or an intervention for NMAD-BIC, hoping that on the line right now, you have to follow this patient from the point of the systemic manifestation. So you might just refer them to the pulmonologist for their lung assessment, and you might start them on bronchodilator. They need a frequent immunization since they are more prone to have pulmonary disease, and they might benefit from the lipid-lowering drug. And you have to avoid selectively an aggressive sport, avoiding risk of the splenic ruptures. And you might also give them some kind of reduced activity and advice and selective dietary advice. This will be my last slide. So splenomegaly might be the first symptoms in the patient with a lipid storage disease. Gaucher and acid sphingomyelinase deficiency are rare disease, and usually they need to be kept in mind, and always there is an overlap between both. Keep high suspicion and send both tests at the same times. Enzyme replacement therapy showed a dramatic response in the patient with the Gaucher disease in terms of the safety and efficacy. Thank you very much.
Okay, thank you, Dr. Nadia, for your interesting case that you have presented. Surely, the Gaucher disease and NMAD-BIC have some symptoms they share together. Sometimes it's hard to differentiate, so we utilize the gene testing and the enzyme assay to reach a definitive diagnosis.
Yeah,
Thank you, Dr. Nadia.
definitely. Welcome.
Now we move to our questions and feedback from our from the audience here. So if anybody, if you has questions or feedback or comments regarding the cases that we or the topics that we have presented today. Anyone from the audience? Yes, Dr. Rehab. This is the mic. Dr. Rehab. Please introduce yourself and
Thank you
ask
very
your
much
question.
for the very informative lectures, Dr. Rehab Saleh from Princeton Military Medical City. I have two questions to Dr. Nadia regarding Gaucher disease. We have two of our patients who were on enzyme replacement therapy. On their first presentation, they presented with oculomotor apraxia at the first neurological manifestation, or as the only neurological manifestation, plus the somatic manifestation, which is huge hepatosplenomegaly. My question is the presentation of oculomotor apraxia put the patient as type 1 or type 3? And the second question, is he vulnerable to have more neurological manifestations during his life, or this would be the only manifestation? Thank you very much.
Okay, thank you, Dr. Rehab, for this very nice questions, by the way. I can say maybe this is unfortunate patient because what he presented with is classical for type 3. And this patient, not sure if he is having any other skeletal manifestation, because usually most of the time they will have eye and skeletal manifestation more obvious compared to the hepatosplenomegaly in type 3. And we had two patients like your patient. They were very lucky at the beginning because they thought they might have responsible type 1, isolated type 1. And they've been on enzyme replacement therapy for almost more than 10 years. But unfortunately, and in the second decade of life, they developed the other extra manifestation, which is the ataxia and convulsions. And it was interactable in nature, very difficult to be handled despite multiple anti-epileptic. And this is one of the major manifestation in type 3. So that patient, most of the time, he's having type 3 and he's more prone to have CNS manifestation. but most of the time it's not now, it will appear later. So maybe not sure if molecular was done and who's handling this patient, but he needs a proper counseling. Most of these patients, they will end with the meager, and sometimes it will be very difficult to continue enzyme replacement therapy. Although now it's very early because still we are waiting for a meager changes in the terms of the therapy. And also we cannot tie patient to patient, but most of the time this patient will end it with a meager complication. And what was your second questions? Or that's it? Okay.
Is there be any neurological manifestations? That was the second question, and you answered it, ataxia and another.
Yeah, they will
Thank
have,
you very much.
definitely he will have, but not now. Severe ataxia and interactable convulsion.
And by the way, one of the patients only with somatic manifestations and oculomotor abractia. The second patient, he has bone disease, Turkey. The one presented.
Yeah. Usually they will have this together.
Yeah, and he has chronic headache still investigated, and not, and we don't know the exact reason for his headache. There is a family history of migraine. It could be the reason for that. Thank you, Dr. Nadia, for your
but maybe
answer.
MRI need to be done also on this.
Yeah, sure. It was done. It was unremarkable. Okay, so any questions, feedback, or comments on the lecture that we have presented today? Okay, so I think we'll move to our the people who are attending our days virtually. I think we have more than questions, so we'll move to Q&A. Yeah. So we have questions from our audience who are attending it virtually. The first one, patient with Gaucher disease, they need lifelong enzyme therapy. The second one from the same audience, if you have an index case, do we need to screen for a family member to catch the disease or to do career testing?
Definitely.
Yeah.
So enzyme replacement therapy usually is a lifelong. People, they try to play with the dose only based on their patient situations. But this is from the beginning. When you counsel this patient, this is a lifelong medications. And definitely with the current availability of other alternatives like substance reductions, people, they need to discuss that with the patient, depend on their time. Most of the time, this is for an adult, but usually it's a lifelong treatment, and hardly any patient being stopped. If you stop this patient from the enzyme resistant therapy, they will develop complications, definitely. Actually, we utilize, for the second questions, we are quite lucky when we diagnose a patient in a family, because that will be our route to reach to others when they are asymptomatic or they are in the early stage, or they might not yet have biochemical changes, and sometimes they might not have even a very straightforward clinical phenotype. That will guide us in reaching them in early stage, and that also will avoid a lot of complications, and that will help initiating the therapy on the right time. Not mandatory to start, but always it's good to know who is also other affected in the family. Start of the enzyme replacement therapy in Gaucher depend on the age of the patient. In adult, there will be a different protocol. In pediatric, there is a different protocol. But always, whenever you have an index patient, definitely screening will help. And don't think about the treatment itself. You think about the long-term benefit from identify a genetic condition in a family. That will help you in planning a better life for the rest of the family members in terms of selective premarital screening, in terms of detecting symptomatic patient missed long time in other hospitals. And there is a lot of scenario and example of this.
Yeah, there is a medication used orally for the adult patient with Gaucher disease. So which is Regulostat. So the patient can take it, and there is no any further need to give the enzyme lifelong. Okay.
The enzyme itself not lifelong, but the therapy is lifelong. So you can change from one model to another model of treatment.
Okay, so there's a question from one of the audience. I would love to direct it to Dr. Fahad. So what's the role of bone marrow transplant in Gaucher patients?
So what's the question?
What's the role of bone marrow transplant in Gaucher patients?
I mean, if you look at the bone marrow transplant after the discovery of the treatment, the enzyme replacement therapy, it's difficult. I mean, to see what is the effect of the bone marrow transplant. Or there is no, I mean, there is no any trial that can differentiate or compare the bone marrow transplant to the enzyme replacement therapy. However, if it is, as I mentioned, if the patient is not improving or there is neurological evidence, you may try, such as the type 3, you may try the bone marrow transplant. Otherwise, I mean, the only is to see any study that can compare between the two, which can give you, I mean, which one will be more helpful or with better results compared to the between the two.
Okay, I think the ones with severe phenotype, aggressive type 2 with infantile onset, severe pancytopenia, bone marrow failure, they may benefit from PMT first and then to continue on the enzyme therapy later.
Yeah, I mean, I mentioned that it's after the enzyme replacement therapy and the substrate also, the bone marrow is not that people they are doing it that much. I mean, the study to compare between the two is not there. However, patients, as I mentioned, with persistent, I mean, thrombocytopenia refractory, you may do it, or if there is no improvement, you may think about doing the bone marrow.
Okay. Another one, what's the most serious complication beside osteonecrosis in Gaucher disease? So I would answer it. Type 2, they have like, I mean, type 1, they may have HLH. So HLH induced by Gaucher disease is very lethal and needs treatment. So this is the questions that we have. So thanks for your attending today, and I hope that you gain knowledge and more updates on Gaucher disease and ASMD. Thank you all our audience who attended virtually. So inshallah, see you inshallah with hopefully soon with any next events in the near future, inshallah. Thanks,
Thank you
Sanofi,
very
for
much.
their kind support. Yeah. So we have a dinner. It will be on the 65th Avenue restaurant on lobby left side from here. Thank you.